Well, we've had some great discussions here. Now we're going to turn to Dr. Catalin Toma, who's going to tell us about how we achieve our treatment objectives by hemodynamic guidance. How do we measure success, and what role does hemodynamics play as opposed to just seeing a bunch of clot on a table, for example? So Catalin, enlighten us here.
Thanks for the opportunity. I think this is a great session so far. So I think we talked a lot already about the hemodynamic assessment, the invasive hemodynamic assessment of these patients in the cath lab before, during, and after the procedure. And what is the role of all this? Why are we doing all this? It's multi-layer, right? We need to assess how sick are these patients, and we've already seen that in Sripal's case. It's also very useful in evaluating complications. When something happens in the case that doesn't go in the right direction, assessing hemodynamics may help you understand what's going on and ultimately guide therapy, which is what we're talking about. When are you done with the procedure? What objectives do you need to achieve to be satisfied? Before we get into that, it's important to understand that this is a relatively easy thing to do. You are on the right side of the heart. You go through the RA, you end up in the PA. It's very easy to measure an RA pressure. It's very easy to measure a PA pressure and calculate a cardiac output from the FIC method. These are the three things that you need that are essential. You do not need to do any kind of sophisticated analysis on the fly in the cath lab. And why is that important? Well, the RA pressure is going to tell you about the preload, which you can manage with volume, as we saw, and this is very important. A lot of these patients are preload dependent. A lot of them are dry because they've been NPO for other reasons. They're post-surgical. The PA pressure, we talked a lot about that. This is afterload. You're going to fix that by taking the clot out. And the PSR, or the thick cardiac output, is going to tell you what's happening with the RV function itself. This is where you come in with inotropes if you need to support your patient with the procedure, or start thinking about more advanced mechanical circulatory support such as ECMO. So volume management even made it in the new guidelines. We've already seen this new classification of PE from the new guidelines. And as you can see, it's recommended to keep these patients volume optimized in general, not just during the procedure. And inotropic support for the RV is equally important. I feel that, as we were talking earlier, that using vasopressor support or inotropic support, it's a different animal compared to using the same pressors for the LV, where you don't get the penalty of ischemia here necessarily, and it can certainly help you navigate the procedure. Obviously, you want to avoid things that would make the PA pressure higher, such as phenylephrine and vasopressin. And if the patient is in real dire straits, if you see a really low cardiac output, you can get ultrasound-guided arterial access, have the ECMO team in the room, have cannulas around, so this becomes a scripted progression to mechanical circulatory support as opposed to a crush. So going to the PA pressure, we've seen that the target, the normal level of PA pressure has changed a few years ago with the new guidelines, went from 25 to 20. Of course, ideally, you want to achieve that as your final result in a PE case. May not be always achievable. But that's one of the important numbers that if you are to remember something from this discussions, is this mean PA pressure of 20 millimeters of mercury, because it guides not only the therapy, but what you're going to do afterwards with these patients. So going back to the case that we've seen, how do you put it all together? Well, the one parameter that can help you put both the cardiac output and the PA pressure into one concept is the total pulmonary vascular resistance, which is probably the true measure of pulmonary vascular obstruction. As we saw in the other case, the mean PA pressure didn't change all that much, but the cardiac output has improved significantly. And if you're looking at the TPVR, there's a marked improvement in TPVR by 70% compared to baseline. So you clearly have achieved a therapeutic impact here. We looked at this data in the FLASH registry just to try to understand at which level you're going to have a good result, at which level of mean PA pressure, at which level of TPVR reduction or absolute levels. And these slides only illustrate the reduction levels. If you get about a 9 to 10 millimeter drop in mean PA pressure, you have a good chance of having a good dyspnea result at 48 hours. This is data from TCT from a few years back. Similarly, TPVR predicts, this is model data, this is not actual data points, but model data showing that if you get a TPVR reduction of 1 Wood units, which is not that much, you start seeing a clinical benefit at 48 hours. We're going to have more data on this and sort of crystallize this a little bit more, but I think this is, again, very useful information to have that can be measured acutely during the case. All you have to do is connect the catheter to a manifold and measure the pressures and get PA-SATs throughout the case. So complications. I think the important thing in this field is to prevent complications and not to get to the point where you have to crush patients on ECMO. And it's relatively easy to do that if you do the hemodynamics, you understand where you start from, you optimize the patient before you get deep into the procedure, and you assess these complications as they happen. So complications are rare, but again, an ounce of prevention is worth a pound of cure. So what are we talking about? We see this chest pain, this vagal episode, especially when you go on the left side of the heart. Well, the cardiac output is going to drop. You can remove catheters, maybe give the patient a pause, optimize the fluid status. You can have loss of clot and re-embolization, which you're going to see by an abrupt increase in mean PA pressure all of a sudden. You're making progress, and all of a sudden the PA pressure goes the wrong way, where you have to understand that that's a possibility and re-aspirate usually on the other side. You can see worsening RV function, which again, you're going to measure it by a drop in PA-SAT and hypotension. This is where you come in with inotropes, mechanical circulatory support, specifically ECMO. Hemoptysis and perforation luckily are extremely rare, but hemoptysis is going to be a very obvious event and very scary event for everybody involved. You're going to see a cardiac output decrease and a decrease in the afterload. This is some of the maneuvers that you should do: turn the patient on the side, call anesthesia for bronchial block, and do a limited balloon occlusion. I haven't had the pleasure of experiencing that, but I hope we will stay that way. So the takeaways: always do a right heart cath before and after the intervention. 3 simple things: RA pressure, PA-SAT, mean PA pressure. Manage the patient before you get into the procedure with optimizing the preload and optimizing the RV function. Endpoints for the procedure: if you can achieve a mean PA pressure of 20 millimeters of mercury, that's a good target for hemodynamic normalization. Having said that, if you achieve a mean PA pressure of 20 millimeters of mercury and the cardiac index is 1, that's not a good thing, because that's why the mean PA pressure is low, which is why I think this TPVR marker is more accurate in telling you that yes, mean PA pressure went down, but the cardiac output went up. We're going to have some of the results of this Ferrari 2 data looking at this new technology that we have for aspiration thrombectomy presented at EuroPCR, and really looking forward to a lot of exciting data coming out of this study.
All right, that was a great summary. I love the focus on the simplicity of preload, afterload, and cardiac output, which you beautifully defined, and the importance of obtaining those measurements during and after the procedure, before, during, and after, I should say. So there are a lot of labs that don't have the capability, or the workflow's not set up to obtain cardiac outputs, and perhaps there are alternatives. You mentioned O2-SAT and measuring that before, during, and at various stages during the procedure. Would you say it's important to do that, and would you encourage that? You sort of implied that
Yeah.
You really should have that.
Absolutely. I think that's a key element. When I'm talking about cardiac output, and I think you guys do the same thing in your labs, I'm not talking about doing thermodilutions. These are time-consuming and not necessarily that relevant. I'm talking about thick cardiac output. So very simple, and that may not be entirely accurate in terms of like what is exactly the cardiac output in that patient, but it provides you something to follow out longitudinally.
Yeah,
because if it changes for the better, or if it changes for the worse, that probably it's a true reflection of the RV doing better or worse.
Yeah,
and it's very simple. It's a PA-SAT and a hemoglobin. That's all you need.
Yeah. I think you can do that in radiology suites. You can do that in surgical suites. That's not really dependent on being in a cardiology or cath lab setting, which is important. What about situations? You talked about evaluating during the procedure what's happening in a dynamic way, and somebody might suddenly deteriorate, and sometimes I've had experience in my thrombectomies where the clot shifts, or for example, I wasn't able to get it and it kind of went downstream and actually caused a deterioration because you didn't have the flow around the clot anymore. You impacted, the clot went into a terminal vessel and blocked it off. So how do you manage that? That's question number one. and then I'm going to follow up with another question after that.
Yeah, so one of the more, I don't want to say frequent because it doesn't happen that often, but one of the scenarios that I've seen a number of times is you go on the right side and you clean that up and have good flow. You go on the left, measure the pressures are coming down. You go on the left side, you aspirate and you do an angiogram and you have good flow, but all of a sudden the pressures are up. This is usually because you drag a clot from the left to the right. And the treatment for that is just go on the right and aspirate. You don't even need to take a picture. It's almost guaranteed that that's what happened with this patient. For the other scenario, when it goes deeper, that's a little trickier because you get from a subocclusive clot to occlusive clot. And we need the tools to be able to reach safely, further down and take the clot out.
Yeah, you said it beautifully better than I. You change it from subocclusive or non-occlusive to occlusive, and that actually is a challenge. So that's actually an important thing for our devices. They need to be able to manage the clot that we have. What about when to stop? This is an age-old question for us dealing with this. I mean, you've gotten the proximal clot out. You see clot more distally. There's reasonable flow. The hemodynamics seem like they're okay. When do you stop? Do you go after some of that more distal clot or not?
Yeah. Well, it depends a lot on what are you starting with and what are the treatment objectives. Is this a patient who is in shock, be it normotensive or frank shock? In that case, you're not going to spend that much time chasing distal clot. Is this a young patient that has an intermediate high-risk P, perhaps with a cardiac index of 1.9, that you optimize and you feel comfortable and you have the tools to achieve this quickly? Then yeah, maybe you will go for more distal clot and achieve more complete resolution of the clot.
Of course, we don't know yet, Vikas, whether taking out the more distal clot or whether better clot resolution will lead to less CTED or CTEPH.
That's exactly right. Yeah, we don't know yet, but hopefully we will get that data in the next couple of years as more and more prospective, large randomized trials on this topic come out. To your point about, so when do you stop? I think for me, it's always hemodynamics. If I get, if my cardiac output is normal, it's time to stop. So let's say, I've done thrombectomy, so whatever I thought I could safely do, so reasonably do, my cardiac output is still low. I would do an angiogram and I would look at the angiogram and ask myself a question. If I started with this angiogram on this patient at baseline, so would I be offering this patient a thrombectomy procedure anatomically? Is there enough anatomic obstruction or clot on this angiogram for me to think they need to have thrombectomy? If the answer is no, so then I would stop, because we still have anticoagulation, which is the age-old standard treatment of choice for these patients. So it's not like we are leaving this clot behind with no treatment. You are still going to anticoagulate that patient. You're still going to follow up that patient. So those would be the two things I use. So when it comes to deciding when to stop.
So Sripal, residual pulmonary vascular obstruction is or is not a major issue?
Yeah, I think this is a question that needs to be answered. I mean, to reframe what you're saying, in the coronary world, we talk about complete revascularization, complete vascularization. Does that apply to the PE space? Should we be as complete as possible? And that's why I like both the viewpoints that, I go in with individualizing. What is our objective for this particular patient? Because the flip side of trying to be as thorough and complete is, there can be patient safety related issues and patient being on the table for too long, etc. But we definitely need more data. I can tell you from our experience, the patients where we leave behind more clot are the ones where the RV also recovers slower. It takes some time, but we do need data, and I completely agree with Vikas that when we leave behind clot, it's not like we're not treating them. They do go on anticoagulation, they get treated.
Yeah, then just to underscore the importance of the hemodynamics and measuring that cardiac output, in your case, with the residual PA pressure was still the same as when you started. Had you not measured the cardiac output, you might have actually said, I better take more clot out. Yeah. But having measured that cardiac output being 4.5 now or whatever, 3x, you could say, hey, I'm okay. Even though there's a little bit of residual clot downstream, I'm okay now. Fair to say that's a good stopping point, right?
Yeah, I agree. And you also have to, the other way to look at this is, what can we achieve safe with the tools that we have versus the residual clot. So in other words, if I give you a tool that can take out all the clot in 5 minutes, we wouldn't have this conversation, right? You'd go and take everything out, right? So that's kind of what we need to strive for and not find reasons why we leave the clot behind, right?
Our goal should always be to achieve as much obstruction relief as we can safely. And as these tools and these devices and the technology comes through, I think we will be able to do that more and more and more.
Very well said.
And I think, I want to emphasize that, flow itself is a big thrombolytic agent. So once you clear the proximal part of it, the residual clot, most of the times, I agree. I do what Catalin was pointing out, like we don't use ECOS or any, putting in some thrombolytic therapy. But most of them get a 48-hour echo and we see a significant improvement in their RVL duration.
Yeah. Well, this is great. Phenomenal set of discussions on an important set of topics. Underscoring the importance of hemodynamics in the evaluation up front, the conduct of the procedure, preparation, the actual procedure itself, and then in follow-up and monitoring these patients hemodynamically for ongoing chronic issues, and really great set of discussions. Maybe each of you could offer one sort of pearl or important take-home point that you'd like to emphasize. Start with you, Sripal.
Yeah, I want to emphasize PE is a hemodynamic problem. So hemodynamics.
Fantastic. Vikas?
So if your acute pulmonary embolism patient in the hospital survives the acute event, you're not all done with that patient. Follow that patient, see that patient, get that patient to a normal, complete recovery 100% of the times.
And in as much as I talk about invasive hemodynamics all the time, I think you have to get in the habit of evaluating the patient as a whole. Look at the CT, don't read the radiology report, look at the echo, go see the patient, what they look like, and then you're going to have pretty much all the data that's going to tell you what the hemodynamics are showing in the cath lab.
Fantastic. This is about taking care of the whole patient, and it's not just a procedure. It's a management of a patient from start to finish. That said, thank you all very much. This is a fantastic conversation. Appreciate the sponsorship of Jupiter to have this opportunity to discuss the importance of hemodynamics in management of acute PE and chronic PE for that matter. Signing off now.